Welcome to Dental XP. I'm Kostas Valavanis, and for the next few minutes I'll be sharing with you a surgical video. This is the pre-op clinical picture. The right central incisor is the tooth of the problem. It is fractured and it has a cyst mesially. It also has a not so aesthetic restoration as we see, and we're dealing with relatively thin tissue biotype. But overall, the gingival display is beautiful, and the margin of the right central incisor is 0.5 millimeter to 1 millimeter more coronal than the margin of the neighboring incisor, in our favor, of course. Here, in the panoramic view of the CT scan, we can see clearly the fractured tooth and the mesial defect cause of the fracture. So let's start. We start by using a 15C blade intracircular. We mobilize the tissue, first buccally and then palatally, always very careful and slow in order not to injure our papillas, especially when we're dealing with thin tissue biotype. We like to do that prior to extraction because the shape of the crown helps directing our blade. Of course, when we're dealing with restorations, many times the non-perfect margins makes our life a little bit more difficult. We will then use a thin periotome to mobilize a bit further apically and also determine where the level of the bone is. After we have completed, we will use our forceps with elliptical round movements in order to extract the tooth without damaging the buccal plate. We will here remove the crown and the post, as we see, and then we will use again our blade by taking advantage of the convexity of the root in order to guide the blade in the proper direction. After that, we will use a very nice periotome from Depela in Switzerland, which has the shape of a boat, and it's very pointy and very solid. We can also hammer it in between the root and the bone in order to mobilize fractured roots. We'll see here how deep it can go, and we will extract the palatal part of the root. You see here, without injuring the papillas. We will continue by extracting some additional fragments of the palatal part of the root. It is very important to understand that it usually takes us longer to extract the fractured root than to place the implant. So we will then extract also the buccal part of the root. You see here we can go quite deep mesially where the defect is, and finally mobilize the buccal part of the root as well. After we mobilized it enough, we will use again our forceps, again with elliptical round movements in order not to injure the buccal plate. We see here, while removing it, the defect we have on the mesial aspect. It is quite big, but antibiotics prior to surgery, we know this from endodontics, help us concentrate the cyst in order to be able to remove it in one piece. We will use our curettes in order to mobilize the defect furthermore, always very cautious not to injure the mesial papilla. And after we mobilized it enough, we will use our blade in order to remove it from the base. We then again use our curettes in order to make sure that our extraction socket is thoroughly clean and we remove any cyst remainings. Next, we will use our round burr in order to create a step more palatally to direct our pilot drill. The pilot drill I like to use is a 2.3 pilot drill. You see here we will change the inclination towards the pilot, and once we have completed, we will use a 2 to 2.7 osteotome from stoma in order to have a better primary stability with our implant. We then check the level of the bone with our probe, and if we need, we can go deeper. We see here the three-dimensional positioning of our final osteotomy in order to place a 3.5 13 millimeter in-cone from Teca France. You see it here, the aggressive threads on the apical part helps us stabilizing our implant with 70-80 Newton centimeters. I do not like to use rotary instruments. The reason is that we have created a thin wall in between the extraction site and our osteotomy, and with rotary instruments we might destroy that. So I always use a straight handle, and my left hand index always protects me from misguiding the implant apex to this thin plate. So in this way we will place our implant slowly in the preferable position, and then we will remove our handle to check the three-dimensional positioning. You see here the implant placed. We are 2 to 3 millimeters below the free gingival margin, and we left a gap in between our implant body, quite a big gap, and the buccal plate. Following that, we will control the height level of the buccal plate, and we notice here that we lack maybe 1 millimeter. So what we will do is we will place a collagen membrane and augment the area. Prior to that, we have already placed a 2 millimeter gingival height abutment. This abutment can also be used as a final abutment, so we can do one abutment one time. Of course, I prefer contoured abutments for this purpose, so in this case most probably we will change once. We see here the membrane placed. My assistant will hold it in place, and I will start augmenting the area with a non-resorbable or very slow resorbable bone substitute material. We will use at the end our probe in order to make sure that we pack well the bone substitute material and that it runs all the way in between the implant body and the buccal plate. Once we have completed, we proceed with the sutures. We always place 2 vertical mattress sutures in this region. The distal one is already placed. We will see here the mesial one. You notice that we enter 1.5 to 2 millimeters above the free gingival margin and more centered to our implant body. And we will go out deep in the palate in order to have a wide base and a more stable suture. We do not like to suture conventionally in this region over our papillas because we tend to push them up. With these 2 mattress sutures, we will be able to stabilize and seal the area in a preferable position. We will create a small gap in between the free gingival margin and our abutment, which will seal and close in a matter of hours. So this is not a problem. You see here we will go out almost in the same position we entered from the buccal aspect, and finally we will keep the area sealed and maintain, as we see here, a sound soft tissue architecture. This is the final radiograph where we see the 13 mm TECA implant, and finally we will use a silicone index in order to fabricate the first provisional restoration from her initial situation. We used a very light color material in order to highlight the contours of the provisional. We can see it here before we modify it, and after we modify it, we notice how much material we removed in order not to push composite under the tissue. Composite is non-biocompatible, so we like to keep it supragingival. We will then use resin in order to cement our provisional restoration, and we see in the first post-op clinical picture that we left a gap between the tissue and the provisional restoration. 1 week after surgery, we see that the tissue moved coronally, and we gained tissue not only vertically but also horizontally, which will give us the opportunity to play and push the soft tissue in order to sculpture it in the ideal position with our second provisional restoration after 3 months. Here we added some composite interproximally for aesthetic reasons. Our first provisional is never that beautiful because it needs to be shorter on the incisal edge in order to protect our implant from shearing forces, and as I explained before, we like to have it short also in the interface with the gingival margin. All this makes our crown short and not beautiful. On the second part of this presentation, we will show step by step how we create our second provisional restoration, you see here, and finish with a definitive restoration and the final outcome. Thank you all for your attention.